Bom dia a todos. Um prazer de estarmos iniciando mais um Hepato Pernambuco, Liver Talks. Hoje teremos a discussão de hepatites virais, tratamento e outcome. Antes de começar as palestras propriamente, teremos alusão ao Julho Amarelo, e é com grande satisfação que nós iremos apresentar o Dr. Leandro Soares Sereno, que está substituindo aqui o Dr. Javas, que é vice-diretor da OPAS. O Leandro, ele é assessor de prevenção e controle das hepatites virais e do Departamento de Enfermidades Transmissíveis e Determinantes Ambientais da Saúde, da Organização Pan-Americana de Saúde. O Dr. Gerson Mendes Pereira, que é diretor do Departamento de Doenças de Condições Crônicas e Infecções Sexualmente Transmissíveis, e secretário substituto do secretário de Vigilância e Saúde do Ministério da Saúde. E doutor Carlos Varaldo, o senhor Carlos Varaldo, que é o presidente do Grupo Otimismo, representando aqui as organizações não governamentais. Cada um de vocês terão de 5 a 7 minutos para fazer a sua apresentação, colocando a importância das hepatites virais para o Brasil, para a América Latina e para o mundo, nesse período tão importante que é a alusão ao Julho Amarelo, que damos início neste ano de 2021. Leandro, seja bem-vindo.
Obrigado, doutora Leila. Bom dia a todos. Eu inicialmente gostaria de agradecer, parabenizar a organização do evento, a doutora Leila e toda a organização por manter, né, a continuidade desse evento que é tão tradicional, tão importante para a especialidade da hepatologia, e também agradecer o convite para a Organização Pan-Americana de Saúde em participar nesse espaço em um tema tão relevante e importante que são as hepatites virais. Para mim é um prazer e uma honra poder representar a organização, discutindo um pouco e apresentando a nossa perspectiva, né, em relação à eliminação dessas doenças como um problema de saúde pública, não? E um marco muito importante, né, da mobilização em torno das hepatites virais, né, que permitiu que ela passasse de uma epidemia silenciosa há muitos anos para uma doença já com metas específicas de eliminação. Isso é um pouco mais recente, mas a mobilização dos países membros da OMS, que reconheceram, né, as hepatites como um problema de saúde pública lá em 2010, um pouco mais à frente aprovaram a estratégia global, né, do setor saúde para a eliminação das hepatites, e aí confirmando, definindo, né, esse documento definia realmente o que seria a eliminação, com a redução de incidência, redução de mortalidade e indicadores de cobertura de serviços, né? Mas também por que isso foi possível, né? Primeiro, por reconhecer a importância, né? Estamos falando de uma doença com uma carga muito grande, são estimados 250 milhões de pessoas com hepatite B, 70 milhões de pessoas com hepatite C globalmente, o que causa em torno de 1 milhão de mortes a cada ano e 3 milhões de novas infecções crônicas, né? Isso de maneira global, e também isso aliado aos avanços tecnológicos que se estavam observando no campo das hepatites virais, que facilitariam e acelerariam o acesso, né, ao diagnóstico, né, com testes rápidos, provas moleculares point of care, estadiamento não invasivo, e especificamente para a hepatite C, a revolução literal no tratamento, né, com a introdução dos antivirais de ação direta, né. Com tudo isso possibilitou então uma resposta organizada a nível global para alcançar essa eliminação, né, das hepatites virais. E a gente tem observado, né, alguns avanços em frente, né, até a eliminação, principalmente no campo da prevenção da transmissão. Temos, por exemplo, sistemas de segurança de sangue e hemoderivados bem robustos, né? Avanços importantes na questão de segurança do paciente e controle de infecção em ambientes de saúde, além de programas de imunização historicamente bem fortes, com adoção bem precoce das vacinas de hepatite B, ainda no final dos anos 80, início dos anos 90, o que levou a região das Américas, por exemplo, a já ter alcançado a meta de eliminação da transmissão perinatal de hepatite B, que a gente definiu, que foi definido como uma prevalência de 0,1% de hepatite B entre crianças de 5 anos de idade. Né? Ainda também observamos um avanço muito importante na adoção de políticas e definição de planos nacionais, estratégias nacionais para controle e eliminação das hepatites virais, aqui principalmente na região das Américas, mas infelizmente esses avanços na prevenção e nas políticas não foram acompanhados de uma expansão no diagnóstico e tratamento. Uma proporção muito grande de pessoas que vivem com hepatite B e hepatite C ainda não conhecem seu diagnóstico e uma proporção ainda menor estão recebendo acesso ao diagnóstico. Alguns países estão mais avançados nesse ponto, como o Brasil, né, que tem um programa em expansão e acelerado, que vamos ouvir um pouco mais depois. Mas, em nível regional, na América Latina e Caribe, principalmente, temos essa barreira. Não? E os desafios, principalmente, que os países enfrentam, né, para poder acelerar essa resposta, estão aliados a uma limitação da alocação de recursos, né, orçamentário doméstico para a resposta, né, temos uma limitação dessas respostas nacionais, o que é afetado principalmente também pelo elevado preço dos tratamentos, elevado preço das provas diagnósticas, apesar dos avanços recentes em reduzir esses preços, né, mas ainda assim alguns países ainda têm certa dificuldade, questões de patentes e registros nacionais complexos, o que limitam o acesso a esses medicamentos, e mais recentemente esse impacto bem forte, negativo, que a pandemia da Covid está causando nas respostas, apesar da recomendação de que os serviços de hepatite são serviços essenciais, que devam ser mantidos durante a pandemia, vários países têm reportado a interrupção desses serviços, né, durante a pandemia. E as hepatites, elas têm, né, é viável eliminar as hepatites, a gente, para alcançar e superar esses obstáculos, algumas iniciativas, alguns conceitos são muito importantes, por exemplo, com essa limitação de recursos, a integração da hepatite com outros programas é um movimento bem natural para utilizar a estrutura que já existe, seja de programas de HIV, programas de saúde mental, ou até de doenças crônicas não transmissíveis, que poderiam ser utilizados para expandir a expansão do tratamento, a simplificação e padronização das guias diagnósticas e tratamento, dado esse avanço tecnológico que hoje permite essa simplificação, e também essa simplificação vai permitir a expansão do cuidado para, por exemplo, a atenção básica ou o manejo de cuidados por outras profissionais não especialistas, médicos, mas também considerando a inclusão de outros profissionais, como a enfermagem, que poderiam principalmente apoiar em questões, em atividades de prevenção e na ampliação da testagem e diagnóstico das hepatites virais, né? E um último ponto também que seria muito importante é a participação social, né? A sociedade civil, ela pode mobilizar, a sociedade civil organizada pode realizar mobilização social, conscientização, promoção da saúde, atividades extramuros, mas também o que nós temos observado é que existe uma incidência muito grande de influência na política, até de alto nível em vários países, e os países que estão mais avançados na questão de planificação, de planejamento e resposta das hepatites virais são os países que incluíram a sociedade civil desde os primeiros momentos na implementação e na planificação. Então, assim, basicamente, a mensagem final seria que as hepatites virais, temos um plano de eliminação, a eliminação é viável, temos umas barreiras realmente, que são acesso ao diagnóstico e acesso ao tratamento, mas a mensagem é que as hepatites, elas não podem esperar, as pessoas que estão vivendo com hepatite não podem esperar para serem identificadas, e as pessoas que já foram identificadas não podem esperar para receber o tratamento e a cura, no caso da hepatite C. Muito obrigado.
Obrigada, Leandro. I'd like to ask only 1 minute if to Professor Didier Samuel. It's a pleasure to have you here. The first minutes we talk in Portuguese because you present our friends to Brazilian planning of the elimination of viral hepatitis. Then we have OPAS represent here, Health Minister here as well, and the non-governmental organization in these debaters. In 12 noon, we start your scientific program. Thank you very much, Professor Didier. Gerson?
Alô, bom dia para todos. Eu queria, em primeiro lugar, saudar você, Leila, saudar Leandro, que fazia muito tempo que eu não o via, saudar Araújo, né? E dizer da importância, né, da gente trabalhar as hepatites virais no país como um todo, né? Eu sempre digo, né, que eu estou no Ministério há pouco mais de 30 anos, né, e vi o SUS nascer, e vi o programa de AIDS nascer, que surgiu da área de dermatologia sanitária, né? E aí, quando foi em 2009, né, as hepatites virais, elas entraram, né, para trabalhar junto aqui no programa de AIDS. E a gente chamou esse departamento de AIDS e hepatites virais. Eu me lembro que, na época, foi muito complicado, eu acho que o Leandro citou importante agora, que é interessante a gente juntar programas, né, para que a gente possa melhorar a performance deles. E, naquela época, em 2009, né, as pessoas ficaram muito apreensivas, achando que a AIDS, por ser um programa muito forte, iria engolir as hepatites virais. Muito pelo contrário, né, eu acho que, pelo contrário, a gente pode observar, né, que as hepatites virais no Brasil elas sofreram um impulso muito grande, né? E já em 2019, né, a gente criou, né, esse novo departamento que a gente chama Departamento de Doenças de Condições Crônicas e Infecções Sexualmente Transmissíveis, que além das hepatites virais, a gente também incluiu a hanseníase e a tuberculose. E a gente colocou 6 prioridades que nós achamos muito importantes e elas têm muito a ver com as hepatites virais. A nossa prioridade 2 é ampliar o diagnóstico das hepatites virais, com foco nas hepatites, da hepatite C, pensando na estratégia de eliminação da doença até o ano de 2030. A gente também tem a prioridade 3, que é reduzir a transmissão vertical da sífilis da hepatite B, né? E aí é muito interessante, porque na hora que a gente pensou, lá em 2016, que a Organização Mundial de Saúde, Pan-Americana da Saúde, elaboraram a estratégia de eliminação das hepatites, já em 2017 a gente conseguiu, né, pactuar junto com o Ministério da Saúde, o CONAS e o CONASEMS, que é muito importante, né, a eliminação, o plano de eliminação da hepatite C. E aí a gente pensou, bom, como é que a gente vai fazer isso, né? A gente precisa trabalhar a capacitação de pessoal, a gente precisa ter medicamento, né? A gente precisa ter um sistema de informação que possa monitorar esses pacientes. Aí a primeira coisa que a gente fez nesse momento, né, foi a gente modificar o componente dos medicamentos de hepatites. A gente tinha um componente especializado, a gente passa as hepatites, os medicamentos de hepatite, da mesma forma que os medicamentos de AIDS, para o componente estratégico. Isso é uma coisa importantíssima, porque a gente sabe que na hora que a gente muda isso, a gente consegue diminuir a burocratização no tratamento desses pacientes. Antigamente, o paciente demorava 6 meses até o diagnóstico, para a partir daí ele pegar o medicamento. Hoje, a gente tem medicamentos na ponta. Isso foi, a gente agora está celebrando o ano dessa mudança do componente das hepatites, dos medicamentos das hepatites virais. E aí, uma coisa que é mais importante, a gente pegou recursos do SUS e compramos aproximadamente 40 mil tratamentos para o diagnóstico, para o tratamento das hepatites. E esse tratamento é uma briga, né? Acho que o Leandro falou uma coisa que é muito interessante, quando a gente fala do tratamento das hepatites, é um tratamento que custava muito caro, né? Lá nos anos 2015, 2016, a gente tinha um tratamento que custava aproximadamente $10 mil, né? Na hora que a gente vai trabalhando a questão dos PCDTs, hoje a gente tem um tratamento que custa pouco mais de $1.200. Então, a gente conseguiu comprar medicamentos. Eu acho que a pandemia atrapalhou bastante, né? O que a gente precisa, basicamente, hoje, né, é aumentar o diagnóstico das hepatites C, né? Porque hoje eu posso dizer para vocês, com toda sinceridade, que o Brasil tem 40 mil tratamentos para hepatite C. Agora, sim, a gente sabe que a pandemia fez com que a gente tivesse uma diminuição muito grande, né, no diagnóstico das hepatites, e não só das hepatites, né, a gente teve uma diminuição no diagnóstico de HIV, AIDS, de sífilis, da tuberculose, da hanseníase, e a hepatite entrou nesse rol de diminuição do diagnóstico de hepatites, do diagnóstico. E aí, o que a gente pensou? O que a gente vai fazer, né, para que a gente possa aumentar o diagnóstico, né? Eu acho que o trabalho com a sociedade civil é importante. A gente está fechando um trabalho com o Rotary Club, né? De modo que a gente possa buscar o diagnóstico da hepatite C em mais de 300 municípios do país, principalmente aqueles mais importantes, com relação ao número de casos. A gente está trabalhando com questões relacionadas à microeliminação, né? Da hepatite C, né? E, principalmente, né? Trabalhar editais para que a gente possa buscar o diagnóstico. Porque eu sempre digo, né? Agora a gente tem o tratamento, mas a gente, por conta da pandemia, a gente perdeu muito ainda no diagnóstico. Então, acho que o que é importante, né, é que essa publicação da portaria 1537 de 2020, que é a mudança do componente, e principalmente, né, a gente tem que utilizar algumas coisas que a gente sabe que são muito boas, né, que nós temos um ciclone para o HIV/AIDS, e a gente está desenvolvendo, implementando um ciclone para as hepatites, de modo que esse sistema ele sirva não somente para que a gente possa acompanhar o tratamento desses doentes, porque esse sistema também vai servir como de vigilância, porque pode ser que as pessoas sejam diagnosticadas no serviço privado e, a partir daí, no momento em que eles vão buscar o medicamento no serviço público, a gente vai conhecer o tamanho da problemática da hepatite. Já falei um pouco da microeliminação, e a gente está trabalhando agora, né, para melhorar o diagnóstico, um aplicativo, né, que a gente possa trabalhar a questão de uma árvore de decisão para o rastreio, para o diagnóstico e tratamento da hepatite C. Então, assim, eu acho que a pandemia nos criou, né, muito problema, né, mas a gente está, inclusive, trabalhando junto com a SAPS, né, que é a Atenção Primária em Saúde, né, para que a gente possa trabalhar a questão da linha de cuidado e um curso Telelab, né, voltado para o diagnóstico de hepatite B e hepatite C na atenção primária. Então, assim, gente, a gente tem muita novidade com relação às hepatites. Eu acho que a pandemia nos pegou com várias dificuldades, mas eu acho que o que a gente tem que fazer é ser resiliente e ter alternativas, né? E ter criatividade para que a gente possa passar esse momento sem ter maiores problemas com relação ao diagnóstico e tratamento dos agravos de condições crônicas e principalmente da hepatite C, que é uma doença silenciosa, né? Então, eu queria cumprimentar todos, agradecer pelo convite e dizer que a gente pode ter um belíssimo seminário para discutir as questões relacionadas às hepatites virais. Obrigado.
Gerson, muito obrigada aí pela explanação, a importância do que é o programa de hepatites virais para o Brasil, né, para essa luta da erradicação da hepatite C, principalmente. E eu gostaria de passar agora para Varaldo. Varaldo, nós temos realmente 5 minutos, né? Nós já estamos com 1.305 participantes, fechei a sala para...
Maravilha!
2, e eu preciso encerrar realmente daqui a 5 minutos para poder começar o nosso evento científico, tá bom? Obrigada mais uma vez pela sua participação, Varaldo, e pela liderança das ONGs que tão bem você representa em todo o Brasil. Em seu nome, eu saúdo a nossa ONG, a UNAP, a Laís Coutinho, a nossa presidente, que tão bravadamente luta nessa campanha de anos com as hepatites virais em nosso estado. Se abrir seu microfone, Varaldo. Abrir seu microfone, por favor.
Alô, alô? Está ouvindo?
Sim, estamos ouvindo.
Ok, Leila, obrigado pelo convite. São 25 anos de luta. Bem-vindos a todos, Jarva, Gerson, Sereno, todo mundo que está aí. Olha, Leila, eu acho que a gente está triunfando nas hepatites. Eu lembro, 30 anos atrás, 1992, apareceu o primeiro alerta sobre as hepatites na Folha de São Paulo, escrito pelo professor Vicente Amato e Jacir Pastechnar, que é um artigo muito grande chamado Hepatitis no tempo da AIDS, quando nem se conheciam praticamente as hepatites. Isso 30 anos. 25 anos atrás, você começa com o Hepato Pernambuco. Hoje já uma senhora de média idade. Tá? Antes do ano 2000, a gente tem que reconhecer o trabalho do Jarbas Barbosa, que introduziu as hepatites no SUS. E por isso, nós, como sociedade civil, o consideramos o pai das hepatites no SUS. Sem Jarbas Barbosa, não teríamos absolutamente nada. Tá? Em 1998, formamos aqui no Rio, se formou no Rio o grupo de fígado para estudar e tratar as hepatites. Nesse mesmo ano, fundamos o grupo otimismo de apoio a portador de hepatites. Tá? Essa história nos levou a muita luta juntos, tá? Trabalhamos muito tempo juntos, tivemos muito tempo, e atualmente temos um PNHB, e desculpem, eu não gosto de falar de departamento, está dentro da memória, tá? Programa Nacional de Hepatites Virais, que foi a luta que começou em 2002, quando, na época, o Dr. Serra assinou a formação do programa, e a partir daí começamos a crescer. E nesse PNHB, não digo departamento, é um pequeno grupo de funcionários, alguns muito antigos, já são praticamente imobilizados, tá? Que continua fazendo história. São totalmente dedicados, lutam com afinco, tudo isso. E atualmente, com Gerson, como ele muito bom colocou, no ponto que estamos, eu posso falar, Gerson, e todos, e Jarbas, obrigado, porque nós temos um dos melhores e mais atualizados programas de enfrentamento das hepatites do mundo, com medicamentos para todo mundo diagnosticado, com qualquer dano hepático, com os melhores tratamentos do mundo, tá? E é isso que é o triunfo da gente. Nós lutamos para chegar a esse ponto. Falta o diagnóstico? Sim, mas nós, como sociedade civil, hoje podemos fazer muito pouco pelo diagnóstico. Podemos alertar, mas é mais um trabalho do governo, dentro das unidades de saúde, e fazer com que esses testes, esses 10, 15 milhões de testes comprados todo ano, sejam utilizados. E a pessoa diagnosticada tenha um fluxo de seguimento, que não seja abandonado. Então, deu parabéns a todos os que lutamos nesses 25, 30 anos, e parabéns, o nosso sucesso foi total. Muito obrigado.
Obrigada, Varaldo. Eu agradeço a todos os participantes, Gerson, Leandro, e a você, Varaldo. E fiquem à vontade, se quiserem continuar, a sala está aberta para vocês, né? Estou abrindo agora para outros participantes e precisamos começar em 5 minutos o nosso evento científico. Professor Didier, welcome to our meeting once again. It's our pleasure to have you here.
Hello.
Hello, Didier.
Okay, thank you for the invitation. So I will try to share my slide.
Yes, we're going to start in 5 minutes, right?
Okay.
And we're going to speak in English all meeting. Apart from the case presentation, the speakers will talk in Portuguese, but all the slides will be in English, right? Unfortunately, my French is not very good. I only to say merci beaucoup once again to have it to stay in our meeting, and you are very close partner. I never forgot that you received our fellows for 2 fellows of my unity in your department in the Paul Bruce. And also we visit your institution that we, not our copy, but you look careful to translate to this your expertise to our liver institute in Pernambuco here. Now, Adriano, you could to start the video and check that Professor Didier should be okay.
15 anos do IFP, Instituto do Fígado e Transplantes de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Thank you very much to all my colleagues attending the Hepato Pernambuco 2021 Liver Talks webinar. It's my great pleasure to begin this scientific event today with a liver talk, viral hepatitis and outcome. It's also an honor to have my friends Dr. Ruth, Ruth from Amazon, and unfortunately, Dr. Andrea, her father passed away last weekend with COVID, and I will replace her to share with Ruth. And we will moderate this round table, and we will introduce the international debaters and presenters of the clinical case. Welcome to Liver Talk today. First, our pleasure to introduce Professor Didier Samuel from Paris. Professor Didier is also a close friend for a long time. It's not the first time that he presents in the Hepato Pernambuco. And the Professor Didier is a professor of hepatology and the chief of the liver transplantation program from Pro Hospital. Welcome, Professor Didier. Deliver your lecture today about hepatitis B.
Thank you very much for the invitation, and sorry to not be in Brazil. I hope to come next time. So I will speak about HBV cure. Thank you, Linda, for your very kind invitation. You're a close friend. This slide shows you the complex HBV life cycle, and you can see that here we are in the hepatocyte. HBV is entry here. You can see here the nucleus, and there are 2 parts in this nucleus which are very important to understand the persistence of the virus. First, the cccDNA, which is a mini chromosome and which is the template of viral replication, and also the ability to HBV DNA to integrate the host genome. And so these two, the presence of cccDNA and the integration of HBV DNA may explain the persistence of the virus and the inability for us to clear completely the virus. And you can see also that there is a production of HBs antigen from here, this HBs mRNA, as you can see here, which is independent from the rest of the viral replication cycle. And you know also that, which is very important, that the nucleoside analog are acting at this level here And this explains why there is a decrease of the amount of viron and also of cccDNA in the hepatocyte, but there is a persistence of cccDNA despite the action of nucleoside analog, and this may explain the persistence of the virus. So people have tried to define what is the cure of the virus, and in fact, the ideal cure is to have a patient to have no more HBs antigen, presence of anti-HBs positive, no more HBV DNA in serum, no cccDNA, no integrated HBV DNA, and so the complete clearance of the virus. But in fact, we are unable to achieve this, and this will explain why we are discussing today. And indeed, if you have on the left the cartoon, the patient without treatment with the presence of the viron in the blood, and of course, a high amount of virons in the liver. When on nucleoside analog, you have a virus suppression with the disappearance of the viron in the blood, a decrease of the viron in the liver, and a decrease of the amount of HBV DNA, which is no more detected in the serum. Of course, so this is the classical situation on nuke treatment, what we call the viral suppression. The functional cure is the decrease viral RNA and protein synthesis, the loss of HBs antigen, and the seroconversion with appearance of anti-HBs antibody. This is quite uncommon, and this is, I think, the main goal we want to achieve. Of course, the complete cure with the clearance of all the virus, with the clearance of the integrated virus, is currently an unattainable goal, and we cannot obtain this currently. We will see that there are several options to try to obtain the disappearance of the virus and the seroconversion to the disappearance of S antigen and appearance of anti-S antibody. So we will see that we try to inhibit the replication of the virus to reduce the antigen amount through a direct viral suppression, but also immune stimulation and immune response revigoration. And this is now the new aim of treating HBV, the disappearance, clearance of S antigen, the appearance of anti-S antibody. So there are in fact two aspects. First, to target the HBV cycle, or to target the HBV gene expression using antiviral, direct or indirect. And the other aspect is to stimulate the immunity, either the innate immunity or the adaptive immunity, to obtain this clearance of the virus. We will see this. So the first aspect is to try to have an antiviral effect through a direct and indirect viral therapy. Once again, you have here the NTCP receptor for the entry of the virus. You have here the indirect cccDNA targeting, which are the inhibition of the entry of the virus with entry inhibitor, the blocking of the capsid modulation, what we call CAMs, which are acting here, and also the antiviral effect against S antigen through silent RNA, as shown here. But also there is a possibility to have a direct cccDNA targeting through gene editing, silencing of cccDNA, or direct cell death. So this is the antiviral direct and indirect effect. It has been shown by several authors that when you treat with nukes, despite the long-term suppress effect, you have still a persistence of cccDNA in the liver, even after a long term. And this has been shown in many situations, as shown here, and in patients with occult HBV infection and liver cancer. So I will not discuss in depth regarding this aspect, but you have in this cartoon some aspect of direct cccDNA targeting through cccDNA silencing or degradation, or permanent cccDNA mutation with a restoration of T-cell function, or transient cccDNA silencing using immunostimulation. One of the other target are the core protein, and some groups are trying to develop core protein assembly modulators, CPAMs, and core inhibitors anticapsid, which have been used here. So there are in development of anticapsid drugs. And also there are some trying to target S antigen directly, mainly through RNA interference, which targets the S antigen or inhibitor of the S antigen release, as shown here. And to try to decrease HBs antigen and to develop a sort of immune response, to have also an interference with cccDNA regulatory loops. And the problem is the unreleased S antigen in the hepatocyte. And you know that the virus has been discovered in 1963, the S antigen and the test of detection of S antigen in 72, but it was necessary to wait for the last 10 years to find the entry receptor of HBV in the hepatocyte, which is a NTCP receptor, and the NTCP receptor, which is a cholesterol, this is a cholesterol receptor, was the entry receptor, and some inhibit protein against this receptor has been developed, such as the Mircludex bulevirtide. The other aspect is to develop immune therapy, as shown here. This is the other aspect. So you have two types of direct immunotherapy in red, and indirect immunotherapy in blue. So in red, you can see that we may use the checkpoint inhibitor anti-PD-1, which is extremely potent in cancer therapy, and maybe too potent for HBV chronic hepatitis patients. Also try to obtain silencing epigenetic cccDNA. But the other aspect is to stimulate the immune system with interferon plus cytokines. Using this, so you obtain a silencing of the interferon gene. This is an option which has been tested several times. And more recently has been used also therapeutic vaccination as a direct immunotherapy against CD8, TCR engineered T cell, or CAR T cell. So these are some of the aspects of immune therapy against HBV. On this cartoon, you can see, of course, the chronic HBV infected liver and the problem of the integrated HBV DNA, extremely difficult to clear or impossible to clear, as you can understand, and the presence of cccDNA and the role of T cell as a maintenance therapy and interferon gamma and the PD-L1 ligand. So this is another cartoon to show that the two options which can be used are the therapeutic vaccination to try to stimulate the T cell and to obtain the clearance of S antigen, and you know that this therapeutic vaccination until now has always failed, and also to use a checkpoint blockade of the PD-1, PD-L1 pathway. This is currently under testing. So more easy has been the another type of immunotherapy, type of immune stimulation, which is to stop nukes. And indeed, when you stop nukes in patients, you may obtain an hepatitis after the discontinuation of nucleoside or nucleotide analog, and a sort of immune rebound, which in some cases may be able to clear HBs antigen. So it has been shown when you stop nukes, you may obtain a higher HBs antigen loss rate, inactive carrier state in some 20 to 30% of the patient, and of the long-term of therapy in half of the patient in e-antigen negative patient. But you have also to be extremely careful because you have always a HBV DNA rebound. You have also some flare of hepatitis, and in some cases it can be extremely severe. This required a very intensive monitoring, and in half of the patient, a retreatment of the patient. On this figure, you can see that in fact the aim is to obtain a strong immune response when you stop nukes in order to have a loss of S antigen. But in many cases, this immune response is too low to obtain S antigen, but you may observe a flare of hepatitis, and this is one of the dangers of this strategy. This has been done in Greek patients, e-antigen negative patient. You can see that there is a rebound in most of the patients here. And interestingly, after the hepatitis, you can see that some patients lose S antigen, as you can see here. And again, in patients with tenofovir, after 4 years, e-antigen negative patient, here in this trial by Professor Berg, you can see that the patients were discontinued for tenofovir, and in some patients, there was a disappearance in here, you can see in blue, of S antigen after the flare of hepatitis, but not in all patients. And again, in this Asiatic patient, you can see that you may obtain in some patients low HBV DNA and 36% rate of S antigen in this patient. But in the patient with clinical relapse retreated, no loss of S antigen, no clearance. And in this group of patients with virologic relapse, there is a strong virologic relapse. There is almost no patient who lose S antigen. The other option, which is well known, is a combination of nukes and PEG interferon in combination therapy. In fact, this is logical because we hope that it will have additive or synergistic activity against HBV without added toxicity. This may induce CCC DNA loss or control and higher rate of S antigen loss. In fact, this has been done in many studies, and in fact, this is not very effective with either interferon or IL-2, and we have failed to demonstrate a strong clearance of S antigen in most of the patients. So I will not detail here, but you can see all the attempts to have new therapy. You can see that the HBV entry inhibitor Mircludex have been used in phase 3 for hepatitis delta, and Professor Wedemeyer will speak about this. But for the targeting on cccDNA, we are still at the preclinical stage. The targeting of HBx the same. Inhibition of gene expression and gene silencing, we are still at very early stage of development, except here we are with a decrease in S level in e-antigen positive patients. The new therapy also against capsid, there was a development by one company with this compound, and there was some antiviral efficacy, but the development is currently on hold. And in fact, currently we have no drug which is currently showing strong effect alone, particularly. And finally, if we look at the stimulation of the immune response, you can see here that there are some phase 1, mainly phase 1 study, which has currently ongoing or targeting innate immune response or adaptive immune response. And particularly, the hope is to have the use of checkpoint inhibitor here, nivolumab. And you can see that it has been shown that nivolumab is able to reduce S antigen, but currently we cannot say that it is a treatment for HBV chronic hepatitis. So finally, on this cartoon, you see all the options we have to try to clear HBV from the entry inhibitor to the targeting cccDNA, targeting S antigen, and the immune stimulation. But currently, this is still not, we have still not the good drug for this treatment. So to finish, what is might HBV cure will look like? We have first two options to target the virus, to modulate the immune system. Probably we will have to combine the treatment in the future. So I cannot answer to the question when. It is clear that we will able to obtain maybe functional cure in some patients. This has been achieved, but the complete clearance of the virus is an extremely difficult goal due to the capacity of the virus, the ability of the virus to integrate HBV, the host genome. And finally, this is my team here and Paul Bruce. And once again, thank you very much for your very kind attention and your invitation.
Thank you very much indeed, Professor Didier Samuel, for your excellent presentation. And now we're going to move on to Dr. Ana Ruth to present the Professor Patrícia Lofego.
Good morning, all. I would like to first thank you, Dr. Leila and your team, for this participation. Congratulate the 25 years of this great event that is part of the history of hepatology in Brazil. And now I present Dr. Patrícia Lofego to present the first case report. And Dr. Patrícia is a gastroenterologist and hepatologist of the Clinical Hospital of the Federal University of Espírito Santo. Dr. Patrícia.
Boa tarde, muito obrigada, doutora Leila, pelo convite para participar desse brilhante evento, Hepato Pernambuco. Eu vou compartilhar aqui minha tela para apresentar o caso. Eu vou apresentar esse caso de um paciente de 56 anos, masculino, branco, casado, lavrador, natural e residente em Alfredo Chaves, que é uma região do interior do Espírito Santo. É um paciente assintomático que veio encaminhado para o nosso ambulatório por apresentar alteração de enzimas hepáticas em exames de rotina. Ele apresentava uma ST de 50, uma LT de 73, uma gama-GT de 40, uma fosfatase alcalina de 74, uma bilirrubina de 0,97, albumina de 4, uma atividade protrombina de 85% e um HBsAg positivo e um anti-HCV negativo. Na história patológica pregressa, esse paciente tinha uma história de uma cirurgia no joelho há 15 anos atrás, negava outras doenças, negava transfusão de sangue. E na história familiar, ele também negava casos de hepatite na família. Na história psicossocial, negava tabagismo, negava alcoolismo e negava uso de drogas. Ao exame físico, o paciente apresentava altura 1,78 m, 76 kg, com um índice de massa corpórea de 23,9, paciente em bom estado geral, lúcido, orientado, hidratado, normocorado, anictérico, com a pressão arterial de 120/80, um abdômen flácido, indolor, sem hepatosplenomegalia, sem sinais periféricos de doença hepática crônica, sem edemas e com o restante do exame físico normal. Nós, então, fizemos uma hipótese diagnóstica de um paciente com hepatite crônica pelo vírus B e solicitamos exames adicionais para complementar a investigação dessa hepatite e pedimos também que ele fizesse investigação na família. Numa segunda visita, esse paciente relatou que ele tinha usado uma garrafada, além de um complexo vitamínico e um lorazepam. E trouxe uma TGO de 143, uma LT de 192, com antígeno HBeAg negativo e anti-HBe positivo, uma carga viral, um HBV-DNA de 170 mil unidades internacionais, com 5,23 de log, uma creatinina de 0,9 e um exame de urina normal, com clearance da creatinina normal. A ultrassonografia de abdômen era normal, exceto pela presença de 2 pequenos pólipos de 0,2 centímetros na vesícula biliar. A endoscopia mostrou uma gastrite enantematosa leve. E a investigação familiar desse paciente, ele tinha 7 irmãos. nós conseguimos investigar 3 irmãos que apresentam, um irmão e 2 irmãs tinham a sorologia HBsAg negativo, com anti-HBC positivo e anti-S positivo, demonstrando aí um agrupamento familiar de casos de hepatite B na família dele, com 3 irmãos com um histórico com infecção passada pelo vírus B. Então, nós fizemos um diagnóstico de uma hepatite crônica pelo vírus B, HBAG negativo, o paciente tinha uma carga viral alta, tinha transaminases alteradas, e nós iniciamos o tratamento desse paciente com análogo de nucleosídeo com tenofovir 300 mg por dia, de acordo com o PCDT brasileiro. Esse paciente foi mantido em acompanhamento com consultas médicas regulares a cada 6 meses, exames laboratoriais, ultrassonografia e carga viral a cada 6 meses. Essa tabela demonstra um resumo dos exames laboratoriais realizados. Então, quando o paciente, em 2011, fez a primeira consulta, ele era HBsAg positivo, com E negativo, anti-E positivo, a carga viral era de 170 mil unidades, ele tinha transaminases alteradas na primeira consulta, e quando a gente iniciou o tenofovir em 2012, ele estava com as transaminases bem mais alteradas, 143 e 192. A partir do início do tenofovir, esse paciente normalizou as enzimas hepáticas, TJ e TGP ficaram normais. Esse paciente manteve sempre uma bilirrubina, uma albumina, um TAP dentro dos valores normais. A creatinina também era normal, com clearance da creatinina e exame de urina sempre normais. Entretanto, chamava atenção que esse paciente apresentava uma plaqueta de 139 mil, e essa plaqueta manteve-se entre 139 e 150 durante todo o acompanhamento. Em 2013, a carga viral era de 23, em 2014, a carga viral já estava negativa. Essa carga viral era feita a cada 6 meses, embora eu tenha representado aqui apenas uma por ano. E em 2015, ele apresentou um escape, apresentou 36 de carga viral, foi reforçada a adesão ao tratamento, e a partir de então, todas as cargas virais realizadas a cada 6 meses foram negativas. Em 2019, esse paciente nos trouxe um HBsAg negativo. Isso nos chamou a atenção, nós repetimos o HBsAg, que realmente foi negativo, e o anti-S estava positivo. Nós decidimos, então, manter o tenofovir e consolidar essa resposta. Em 2020, o HBsAg continuava negativo e o anti-S positivo. Solicitamos novamente uma endoscopia que excluiu a presença de varizes, um ultrassom que não mostrou nenhuma evidência de doença hepática crônica, e em 2021, agora, com o HBsAg negativo e um anti-S positivo de 79, nós decidimos suspender o tratamento com tenofovir desse paciente. Assim, nosso paciente tinha uma hepatite crônica pelo vírus B, HBAG negativo, com uma carga viral elevada, elevação de aminotransferases, sem evidência de doença hepática crônica, tratado com tenofovir. Esse paciente apresentou uma resposta clínica, normalização das aminotransferases, negativou a carga viral, e após 7 anos de tratamento, o paciente negativou o HBsAg e apresentou uma soroconversão para anti-HBs. Nós consideramos uma cura funcional, consolidamos essa resposta por 2 anos e fizemos um novo ultrassom para descartar a presença de doença hepática crônica, uma endoscopia digestiva para descartar a presença de varizes. Entretanto, esse paciente mantinha essa trombocitopenia estável, e isso aqui chamava um pouco a nossa atenção. Tinha um APRE de 0,42 e um FIB-4 de 2,54. Nós não tínhamos disponíveis a realização de uma elastografia nem do HBsAg quantitativo, mas nós decidimos, baseado na cura funcional consolidada por 2 anos, suspender o tratamento desse paciente. Então, eu queria deixar algumas questões para discussão. Quais os critérios a gente deve considerar para suspender o tratamento em pacientes com hepatite crônica B em tratamento com análogo de nucleosídeos? Segundo, qual a utilidade clínica do HBsAg quantitativo nessa situação? E como seguir esses pacientes em que a gente suspendeu o tratamento da hepatite crônica B com análogo de nucleosídeos? Obrigada.
Thank you, Patricia. And now to discuss this clinical case, I'd like to introduce Dr. Hugo Schenker, titular professor of the Federal University of Rio Grande do Sul, Dr. Susanna Ono, Associate Professor of the Department of Gastroenterology at University of São Paulo, and Dr. Mônica Viana, Professor of Clinical Medicine at the University of São Paulo and Preceptor of Medical Residence in Gastroenterology at the Hospital do Servidor Público Estadual de São Paulo. You have 50 minutes to discuss this case. Thank you.
Great case, Patricia. You raised some interesting points. First of all, there is a little controversy in the first question, because if the patient, imagine if this patient had cirrhosis. We're not sure he doesn't have cirrhosis because you couldn't do an elastography, and even with an elastography would be a little unsure. So because of the platelets, some people would stop treatment in a compensated cirrhotic that has been compensated all his life and never decompensated, and were able to seroconvert from S to anti-S. Some people would stop after consolidation and look very closely. But some people would feel that if the patient had cirrhosis, they would never stop. So there's a little risk there if you are one of these doctors that don't stop therapy if the patient has cirrhosis. Then the fact of stopping therapy in this patient, you might have this little controversy. But myself, I never stop if the patient is cirrhotic. So I would only stop therapy in this patient if I had an elastography, if I was sure he didn't have cirrhosis. But let's hear the other people, because the other two questions, I believe it's I don't need the S antigen to do that, and I would follow the patient very closely after stopping. But I would like to hear the colleagues and Didier Samuel, Professor Didier, about this controversy of stopping therapy if the patient were cirrhotic.
We do not stop antivirals if the patient is cirrhotic, or we have doubts that the patient is cirrhotic, especially now because we are in pandemics. Because when you stop the drugs, you have to follow the patients very closely, because we don't know which patients will reactivate. And especially here in São Paulo, because of pandemic. So in the past year and a half, if the patient is stable, we prefer to follow until the pandemic finish. Then we can have, if the patient have any problems, we can receive the patients in the outpatient clinics. But if the patient is cirrhotic or we have doubts, usually we do not stop. But we have patients that we stop it, but not if we have doubts if cirrhotic or cirrhotic.
Okay, so hi everybody. I'm very happy to be here in Hepatite Pernambuco, this huge and amazing event that's very important for our Brazilian hepatology nowadays. And I want to say, I agree with you, with Suzanne and Hugo. Of course, for me, the most important thing about this case is to know about cirrhotic, if the patient is or not, because we have low platelet count, sustained low platelet count. So an elastography is really necessary in this case. I think, Patricia, I can do for you, I can perform for you if you need. I'm here to help the patient, because I think it's very important. It's very dangerous to quit the medication in a cirrhotic patient. And we know that here in Brazil, what Suzanne said is very, very important. We have much more problem to see these patients like each 3 months, for example. So I think I will be very concerned about this.
Professor Didier?
Yes, personally, I don't stop the treatment in cirrhotic patients. So I never stop in cirrhotic patients because the risk of very severe HBV reactivation is extremely high. Also, we have transplanted some patients to stop by themselves the treatment and who develop liver failure. And in some patients, some patients died without transplant. And so I think the risk of viral reactivation is too high for this patient. So I never stop in cirrhotic patients.
Professor Didier, have you used HBS antigen titers in your unity?
Yes, I think the HBS titer is interesting to follow. And indeed, if you see the decline in HBS titer, I think this is interesting for the decision to stop or not to stop. So I agree that anyway, if you stop the treatment, it is important to have a clear follow-up and cautious follow-up of the patient, because it is difficult to predict what will happen after discontinuation of tenofovir or entecavir. So you have to follow carefully the patient. But the main risk for me is only in cirrhotic. The point is that you have it's difficult to predict what will happen if you stop the treatment. And secondly, you have at least half of the patients who need to be retreated. And the other, we do not know because you have to follow them, except those who lose S antigen and who have appearance of S seroconversion.
I think Professor Marcelo Silva, could you comment? He suggests to do a liver biopsy if you don't have elastography available. Can you Marcelo, can you comment your opinion, please?
Well, it's a question. Good morning, everybody. It's a pleasure to be here. Hi, Didier. Hi, Hugo. How are you? My old friend. Whenever you don't have an elastography and you're concerned, why not going back to the old friend before assuming such a risk of stopping treatment? It's a question for Didier.
What is the question exactly?
Well, the question is...
The old friend is the biopsy.
That's right. If you don't have access to an elastography and you have questions and you're assuming a high risk in this patient because you are concerned about the possibility of being cirrhotic, why not going back to the old friend?
The problem is that first, liver biopsy is heterogeneous. I think it is important to keep in mind how was the liver before to start the treatment. Indeed, in hepatitis B, even if you have the fibroscan or elastometry, the problem is that when you treat the patient with NUCs and tenofovir or entecavir, you have anyway a decline in the elastometry.
Yeah.
So you have a decline. But in fact, a cirrhotic patient, most of the cirrhotic patients remain cirrhotic with a low elastometry on treatment. So the value of the fibroscan for HBV on therapy is difficult to assess. And so my personal view is to take into account how was the liver when you start the treatment.
Excellent.
Also, can I add just one thing? I think losing S antigen, especially if you have a seroconversion from S to anti-S, is a good endpoint. We like that. But remember that after the patient is 50 years old, this changes a little bit. And there are some Asian studies showing that if you seroconvert after you are 50 years old, you had too many years of virus present, and the impact is reduced of the seroconversion. So I wouldn't use this seroconversion as a very good marker that everything is okay with the patient, because he has more than 50 years old. And the hepatocellular carcinoma, it comes especially after this age.
I think that's the third question. How can you follow in these patients after you stop treatment? I think you close, very close every 6 months, every year? How can you manage these patients in your units?
No, I think when you stop the first year, you have to be more careful and see the patient every 2 to 3 months. And then in the second year, you can see every 4 months. And then in the third year, maybe every 6 months.
I'd like to hear from Professor Wedemeyer. I'm not sure if he's on, but first of all, thank you very much, Heiner, to join us. I'm not sure if you're on at the moment, but I'd like to listen to your opinion about this case. Hi, Heiner. Thank you very much indeed to join us from webinar, but next year, hopefully that you could join together, everyone.
No, repeat.
So sorry for that. Too many things in parallel. First of all, hello everybody. It's great that you involving me, and so it's really a pleasure being here. I had a call in between, so I could not follow the case in detail. Therefore, I would not like to comment here at this stage. Okay.
No. Right. Now, the case is the patient's 50 years old that has a response for tenofovir, and after 2 years, he loses the HBV DNA for the last 2 years, and they stop the tenofovir. The patient don't have elastography to show that he is cirrhotic, but how, in your opinion, how can you, when you stop the NUC therapy in patients with cirrhotic or not cirrhotic?
So let's say stopping NUCs after 3 to 4 years in non-cirrhotics is clinical practice, I have to say. So this is pretty much accepted in Germany. It's part of our guidelines even, that in patients who start off NUCs, I think that's the easy part. And we are quite strict that patients who start in cirrhosis, that we do not stop them yet. That's, I think, the short message. Whether after 5, 6, 7, 8 years, if somebody started cirrhotic, if they have really improved in liver elastography, whether there might be an option to stop, that's something I think to be discussed on an individual basis. But let's say, quite frankly, the patient who did not start off with liver cirrhosis there we give them a chance. It's even the other way around, because by stopping they may lose S antigen in 10 to 30%, depending on the ethnic background and depending on the HBV genotype. I think that's a key point. And if you continue NUCs, nothing is happening on S antigen. So but stopping may be even a good thing. And if we do not stop, we don't provide the option to the patient that they may lose S antigen. So that's an option. That may be different for, let's say, Caucasian versus Asian patients. In Asian patients, this is less likely. And we have let's say, the stopping NUCs is a hot debate on our national meetings here. So that's a big topic, I have to say.
Dr. Leila, I would like to say that I really think this patient is not cirrhotic patient, and I have been with this patient for a long time, every 6 months, and he doesn't like to me to be a cirrhotic patient, and that's why I stopped the treatment. But I can't be absolutely sure that is. Certainly, that's sure.
Yes, the patient has not portal hypertension. I think you're very confident to know that's probably no cirrhotic patient. But as Monica asked that could do elastography for you, it's okay.
Very nice, Monica. I would love it.
Heiner, and how can you follow your patients after you stop NUC therapy? Every 6 months, every year? How can you manage your patients there?
So first of all, I think it's very important that most patients will have at least a transient HBV relapse, right? And this relapse is different if you stop after tenofovir or after entecavir. So the relapse is much earlier after tenofovir than after entecavir. So for us, if I stop a treatment with a nuke, and if he has been receiving entecavir, then I usually call him back once just for a consult after 3 months, nothing is happening, and then this flare may happen at week 24 after stopping. If I stop after tenofovir, I usually call him back already at week 8 after stopping, just to make sure that there's not a severe flare. So then I call him back after 8 weeks, after 16 weeks, after 24 weeks, and then after 48 weeks, and thereafter, let's say, on a yearly basis, and then we simply have to see what is happening on S antigen and the other things. So that's what I can say at this stage.
Okay, thank you very much, Leila. We have 50 minutes, so we can go to
I have to move on to the other speaker. Huh?
Okay, we can go to the next case.
No, you're going to have the next presentation for Professor Marcelo Silva, Head of Hepatology in the Liver Transplant Unit at the Austral University Hospital and board member of the Clinical Research Unit at the Austral University Biomedical Science Faculty in University of Buenos Aires. Now he's a president of the Latin American Association of the Liver Studies. Marcelo, it's a pleasure to have you here. And tomorrow, I think we'll be together, Brazil and Argentina final cup, and Saturday football.
Leila, it's really a pleasure to be here, and I still remember my first time there in Pernambuco. That after the meeting, we did have a formal soccer game against HCV patients that were treated with interferon, and physicians won the game. That was the only opportunity. So really, it's a pleasure to be again with you, and wishing that next year we're going to be able to have a presential kind of meeting. I'm sorry for my slides in Spanish. I was not aware that I was supposed to present in English, but the presentation is on the topic. You know, what about the simplified treatment? Is it feasible in the era of the DAAs? As you had listened before in the previous presentation, I mean, we have more than 70 million persons that are infected with HCV in the world, and that approximately 70% of them are in low and middle income countries. But even worse, this is OPS, PAHO, information from a document that is called La Lupa. The estimated number of cirrhotic patients due to hepatitis C infection in the Americas is higher than 1 million individuals. And if you look in Brazil, 267,000, in Argentina, 48,000. So it's impressive that in the Americas, and this is data, an estimation from 2015, this amount of cirrhotic patients. Everybody knows what are the targets, the goals of the WHO that we're supposed to achieve in 2030. And let me be skeptical about this a little bit, because in Latin America, Brazil is a leading country with a program at SUS, but the rest of the countries were far behind. And more than likely, we're not going to be able to achieve these goals. The reduction of 90% in the new cases, the treatment of 80% of those cases that are eligible for treatment, and reduction in mortality due to hepatitis C, about 65%. We're going to be far behind that. But in order to obtain those goals, we need to be sure that we're going to be able to achieve preventive measures, and perhaps the most important, to expand diagnosis and treatment. You know? And if we are not able to do this, expand diagnosis and treatment, we're not going to be able to take care of the disease. So how to do that? In order to do that, you have been discussing this, is not just to have good treatments or to have cheap treatments. You have to have a system. If you don't have an organized health system, you're going to be losing the game. And that's the difference when you compare Brazilian and other countries, because of the unique SUS that you have there, that in most of other countries in Latin America, we have fragmented and segmented health systems that do not allow us to deliver the treatment. So in order to be brief, we need to have a massive access to diagnosis, We need to improve treatment providers with non-specialists, and we need to decentralize the treatment in the community and have very simple clinical practice guidelines that really follow what needs to be done. This has been already addressed by ASLD and also by ISIL, and I'm going to show you what are the key points of the simplified treatments. In order to be able to get into the simplified treatments, you need to be sure that you don't have cirrhosis, that you don't have an HCC, that you are not in the waiting list, and that if you're a female, that you're not pregnant. And whenever you went through that step, you have to be clear that you know exactly what are the medications that the patient has in order to avoid DDI, to avoid any kind of impact on the previous medications on the levels of the antiviral therapy. And whenever you have gone through that, you're very sure that you can treat patients with whatever you have. If you have GP, you go with GP for 8 weeks. If you have soft valve, you go with soft valve instead of for 12 weeks. And that you don't need intra-treatment any kind of lab workup. And the only thing that you need is to be sure that the patient achieve a sustained virologic response after 12 weeks. And if the patient was one of those patients that was F3, close to cirrhosis, you have to be sure that that patient, despite the fact that cleared the infection, he can develop HCC in the future. And what about the ESIL? It's very similar. What they plan for the simplified treatment in this situation in patient with hepatitis C, that you can start treatment only with a viral load and evaluating the possibilities of different DDIs. No, you don't need to have the genotype in order to start a simplified treatment. You need to understand whether the patient is cirrhotic or is not cirrhotic, and if the patient has hepatitis B or HIV. But you don't need genotype for C. You don't need RAS test if the patient is a naive patient. That's another condition. They need to be naive. And in the case that you don't know, like in the B patient that you mentioned before, the stage of the fibrosis, the length of the treatment should be 12 weeks instead of 8 weeks. And the evaluation of sustained virologic response could be omitted except on those patients that have risk of reinfection. What happened in Argentina? We have our old clinical practice guideline that has been currently improved in 2020, and there we changed our initial definition to treat everybody. In the previous one, we didn't treat everybody. We treat patients only according to the stage of fibrosis. And the difference of this simplified clinical practice in Argentina is that we can treat cirrhotic patients. We can treat cirrhotic patients, but they must be patients with a child A case. And if according to which is the regimen that you're going to be choosing, if it's soft valve, you may be careful with the genotype 3. So it is clear that in order to get into this simplified approach, we're going to need to have either elastography, any type of elastography, or serological test, as you have been shown already, and the link with the Liverpool. With these three tools, we're going to be able to decide whether the patient is a good candidate or not for this simplified type of treatment. What are the different treatments that we have in Argentina and most of the countries in LATAM? You were talking previously about the cost of the treatment. Argentina is a country that has a lot of copies. They are not generics, they are just copies. And those copies are much more cheaper than the original medication, but we have to be sure that the quality is the same than the previous one. So we're gonna go through this, that you know the GP, soft valve, and soft valve box. That are the three ones. I'm not going to spend too much time on this because you know that you have enough information that with GP for 8 weeks, you can treat patients with genotype 1 to 6, cirrhotic, but they must be child A. And the difference with GP is that you can treat end-stage renal disease patients very safely. But if you move into soft well, you're going to realize that you're going to have a better profile in patients that have an advanced liver disease, but you don't have as much information in patients that have end-stage renal disease. But again, look at the impressive numbers that with this medication, you can treat any type of genotype in different stages of liver diseases. And as I mentioned before, with soft bell, you're going to be allowed to treat patients with decomp cirrhosis that's not feasible with GP. And if you are the unlucky one, you're the one that did not respond to treatment, you have this combo, soft bell box, that, as you can see here, in different scenarios, either with non-responder to NS5A or non-responders to non-NS5A, you have a pretty good amount of response. So the bottom line is that we have more than 90% of the infected patients that can get cured with a pangenotypic regimen in hepatitis C. So it should be very easy to test, treat, and cure. No, because if we have the cure in our hands, what is the problem? The problem is how can we reach those infected patients? So the problem, if I have to put it in one word, is the outreach. How to get there? How to get where are the patients to be able to test them, diagnose them, take care of them, treat them, and cure them. And as you can see, there are a lot of gaps in the continuum of care, but one of the most important gaps, at least in my personal perspective, is the gap between the diagnosis and the care, at least in our region, but not only in our region. As you can see in the USA, in this database from the national lab, from the positive patients, not only with anti-HCV, but also with HCV RNA, more than 80% of them did not receive treatment. So there's a huge gap in between diagnosis and treatment. So there are different outreach alternatives. This is a very fancy one that is called the liver care van, that goes to those areas in patients that are former drug addicts or street patients that are not able to reach a hospital, and they are able to achieve a good number of anti-HCV, HCV RNA in different scenarios. So the outreach in this model of a delivered care van has proven to be efficient. But this is the one that I like the most, and I'm biased, 100% biased with this. This is a study that we're running in LA, in most of the countries in Latin America, checking for the medical records in different institutions. As you can see here, at the time that I wrote this slide, we have checked more than 15 different hospitals in the region, and detected more than 3,000 patients with hepatitis C, and 3,200 were positive for chronic infection. Let me be brief with you. We realized that we have at least 50% of the cases that were lost in the follow-up. In a university hospital or in a county hospital, 50% of those diagnosed with the ICD-9 were lost in the follow-up. And when we start searching for them, we realized that at least 24% of the patients who had been diagnosed were not treated, and that they are still candidates for treatment. The other issue that we need to improve in order to have a good impact is to amplify the number of providers. If we're going to be just the hepatologists providing care for these patients, we're not going to be enough, and we need to teach primary care physicians or any other physician that want to treat these patients in order to be able to test, treat, to check the cure, and to retest if there is a risk. So in order to be closing the lecture, the eligibility for treatments, for simplified treatment, we need to understand that the eligible patients are adults with any genotype that are naive to previous treatment and do not have cirrhosis. If they do have cirrhosis, if they do have HCC, if they are in the list of in the waiting list for liver transplant, or if they are co-infected with HIV or hepatitis B or pregnant, they are not eligible for this simplified treatment. And just to share with you a couple of studies, this simplified study in patients that have poor adherence to treatment, 103 patients in which 32% of them lost the adherence. The sustained virologic response rate was exactly the same, 94%. So losing some pills is not going to be always, is not going to mean always that they're going to be losing the response rate. And this is the MINMON study, minimal monitoring approach, where they didn't have genotypification, they delivered the tablets to the patients, they didn't have any lab intra-treatment, and they just have a couple of phone calls on week 4 and week 22, and on week 22 they also determine the sustained virologic response rate. Just to share with you, 396 patients, 399 patients, 383 samples that were able to be checked in week 24, and the sustained virologic response with soft-valve was 95%. So it's impressive. But in order to answer the question, if a simplified and decentralized treatment is feasible, yes, it is feasible, but it requires several different efforts, such as 1, effective therapies, 2, a very clear strategy approach of test and treat included in the local and global clinical in the GPCs, no? 3, strategies of microelimination for those patients that are not able to qualify in the simplified approach of treatment. 4, expansion of providers, of the pool of providers, not only for hepatologists, GI or ID physicians, but also to primary care, or even also for nurses that are coached through telemedicine. And perhaps the most important, the political commitment, as you have been shown initially previous to the lectures. So to conclude, the targets of WHO only are going to be achievable if there is an effective and massive screening, but has to be linked to an adequate care and treatment. The simplified therapy requires only HCV RNA, stratification for fibrosis, and DDA evaluation, and the pangenotypic treatment is simple, effective, and very sure that it's going to help us to enhance treatment to the patients. And it's very critical to amplify the number of treating physicians, and the current data shows that prisoners and addicts can be treated efficiently with DDAs, and patients with cirrhosis and comorbidities, liver comorbidities, needs to be followed beyond the virological cure. Thank you very much.
Thank you, Professor Marcelo. To moderators, Dr. Hugo, Dr. Susanna, Dr. Monica, if you have any question to Professor Marcelo, or also Anna, Professor Didier.
I think it's better to present the Marcia case before and after you debate together. I think it's the best.
Okay. And now we present the second clinical case. I introduce you Dr. Marcia Yazzi of Hepatology Outpatient Clinic of Ilhabela, Pará. Marcia, please.
Olá, boa tarde a todos. Queria agradecer a Leila pelo convite, muito honrada em rever todos vocês e poder compartilhar aqui com pessoas com tanta expertise. Conforme foi nos solicitado, eu vou apresentar um caso que ilustra bastante o que o professor Marcelo acabou de apresentar. Próximo. Trata-se de um homem de 56 anos que fez diagnóstico de hepatite C em um exame de rotina e não tinha nenhum antecedente patológico e virgem de tratamento. No seu exame físico, ele apresentava um sobrepeso, nenhum sinal de doença hepática crônica, tinha um fígado um pouquinho aumentado, amolecido, não havia baço palpável. Em relação às sorologias, ele apresentava sorologias negativas para HIV e hepatite B, e apresentava, em relação ao vírus C, uma genotipagem 1B e uma carga viral de 700 mil unidades, uma carga viral baixa. Em relação aos exames laboratoriais, as transaminases AST de 50, ALT 49, plaquetas 282 mil, hemoglobina de 14,5, albumina 3,9, INR de 1, bilirrubina normal 0,9, creatinina de 1 e uma glicemia de jejum 109. E o cálculo do Roma 6,7. Próximo. Muito bem. Em relação à avaliação, né, do estadiamento dessa doença hepática, utilizamos inicialmente o APRA e FIB4, que afastaram uma fibrose avançada. Tivemos oportunidade aqui na Ilhabela, só corrigindo a Ana, que a Ilhabela está aqui em São Paulo, no litoral norte de São Paulo. Nós fizemos um mutirão de elastografia hepática em 2019 e tivemos a oportunidade de fazer nesse paciente, que mostrava uma fibrose baixa, FIU. Ele também apresentava uma clínica de dispepsia importante, por isso ele fez a endoscopia digestiva. Não foi por conta de pesquisar varizes, visto que a elastografia tinha sinais de fibrose baixa. Ele mostrou, então, apresentou uma gastrite, né, antral e ultrassom uma esteatose. Então, concluímos inicialmente tratar-se de um paciente com hepatite C crônica, genótipo 1, virgem de tratamento, uma fibrose baixa, F1 e uma carga viral baixa também, com sobrepeso e resistência insulínica, ou seja, um paciente muito comum do nosso dia a dia dos ambulatórios. Iniciamos, então, o tratamento de acordo com o nosso PCDT, com sofosbuvir e ledipasvir, por 8 semanas. Próximo. E aqui seria o que nós desejamos, né? Que esse perfil de paciente fosse atendido na atenção primária, que é esse esforço que o professor Marcelo acabou de falar, que nós temos que fazer para que esses pacientes sejam atendidos também pela atenção primária, e com isso a gente consiga ampliar a nossa meta da OMS até 2030, o que a pandemia atrapalhou bastante. Mas, voltando ao caso, ele teve esse diagnóstico em dezembro, conseguiu agendamento em janeiro, isso aqui é vida real, então foi estadiado, fizemos o mutirão em janeiro, ele foi incluído na elastografia, identificamos aí que era 1B e solicitamos o tratamento. No tratamento, esse paciente viajou, voltou, e em junho ele iniciou o tratamento com sofosbuvir e ledipasvir, terminou o seu tratamento e o PCR de 12 semanas após o tratamento era positivo. Então, nesse momento, a gente acredita que até aí fosse possível tratar na atenção primária, e a partir do momento em que esse paciente apresenta uma não resposta ao tratamento inicial, aí sim ele deveria ser referenciado ao centro de especialista na hepatologia. Próximo. Então, aqui ele foi reestadiado, né? Na realidade, não reestadiado, ele foi avaliado pela nossa equipe e foi proposto o tratamento de acordo com o nosso protocolo vigente, sofosbuvir mais GP por 12 semanas. Evoluiu bem, sem nenhum evento adverso, um parêntese, ele não apresentou evento adverso em nenhum dos 2 tratamentos, foi muito bem, super tranquilo, e depois do PCR, 12 semanas após o término do tratamento do segundo, estava indetectável. Próximo. E aqui a gente traz algumas questões, né, referente a essa situação. Qual que seria a razão da gente tratar esses pacientes na atenção primária? Acho que o doutor Marcelo já colocou muito bem. Se a gente não tiver esse esforço, a gente não consegue atingir nossas metas e vamos continuar recebendo pacientes em fases muito avançadas e com aumento significativo de hepatocarcinoma e mortalidade. Esse tratamento é um tratamento com uma alta taxa de cura, né, com baixos eventos adversos. Então, factível de fazer isso na atenção primária. Agora, tem uma outra situação, né? Será que a resistência insulínica poderia ser um fator complicador do manejo desse paciente na atenção primária? É isso que eu queria ouvir a opinião de vocês também. Mas o que a gente nota é que os médicos da atenção primária, eles têm bastante expertise com isso. Mas eu acho que cabe a gente ampliar a nossa abordagem, e mesmo com educação continuada e parcerias com a APS, para que o manejo tanto de eventos adversos, que são poucos, mas das drogas, interações, droga-drug interaction, é muito importante, porque na atenção primária, muitas vezes esses pacientes usam diversos medicamentos e precisamos que a atenção primária entenda a importância de checar essas possíveis interações. E a outra coisa que eu acho que seria interessante de ouvir opinião também é como seria o segmento, a partir do momento que esse paciente cura com o segundo tratamento, ele deve voltar para a atenção primária, a gente dá alta da hepatologia, lembrando que esse paciente tem esteatose, como fica o tratamento da resistência insulínica. Então, eram essas questões que eu tinha para discutir e ouvir a opinião de vocês. Eu agradeço mais uma vez a oportunidade, e a Leila sabe que eu estou no meio de uma situação aqui no hospital, e eu não vou poder ficar até o final do evento, então, muito obrigada. Foi muito bom rever vocês.
Ok, Mônica já está pronta ali para falar, né? Thank you, Marcia. Monica is ready to talk.
Yeah, I'm sorry. Okay, I think this patient, I wouldn't have any doubt. I would treat this patient because he has high chances of cure. And these medications, the medications that we use nowadays, the DAAs, are very safe, without side effects. So I will be okay to retreat. 1B genotype, the FibroScan and the DAPR score are very low. So I think we don't have any doubt about treat. The second, can I go on? The second, ask about insulin resistance. I think, Marcia, it was very good to answer this, because insulin resistance is becoming more and more common in our patients, especially during the pandemic. Everybody gain weight, so we need to take care of these patients. We need to know how to take care of them. People are getting, I think, more and more used to treating insulin resistance in our service. So I think that what we have to pay attention is just the possibility of drug interaction. So just to decide and to monitor this. And the third, about how to monitor this patient, I would be especially concerned about hepatic steatosis, because the hepatitis C, I think it will be very easy to cure. And then I will think that this patient needs to be monitored about HOMA glucoses, because the HOMA score was 6.7. So important insulin resistance. So I will be much more concerned about this after the cure of hepatitis C.
Address a couple of issues in which I agree 100%. One, we are not treating just a viral hepatitis. We are treating patients with liver diseases. That, in this case, the guy did have viral hepatitis C and liver steatosis. No, so we're treating, or we should be treating, two diseases. No, and despite saying this, I do understand that these patients need to be initially treated by the primary care physician. And if they fail, or if they retain the NAFLD, the NAFLD should be in some way delivered to the hepatologist. I mean, we need to be sure that we understand we're not treating just a viral hepatitis, and that when we are proposing the simplified type of treatments, is because we don't have enough hepatologists to take care of all these patients. But once the virus is out, we need to take care of the MAFLD, the NAFLD, the NASH, however you want to call it. It is impressive the amount of HCCs that we're seeing in non-cirrhotic patients with MAFLD or NAFLD. And basically in those that have cleared the viral infection. So there is no question that that patient, while the patient retains the NAFLD, needs to be followed systematically. Nobody knows exactly how, but they need to be followed.
Okay, can I speak? All right. I was very surprised to see that this patient failed the first therapy because he was a genotype 1B with a rather low viral load and an F1 fibrosis and naive patient. So he should have cured the first time around, especially with sofosbuvir ledipasvir, which is a very good medication, even for 8 weeks for genotype 1B. And probably this patient, the adherence was not correct. Probably he didn't take the medications. I can't see why he wouldn't cure the first time around. And there's no impact of insulin resistance on SVR rates with the DAAs. That's very different from what we saw in the interferon era. But they look at every side of this issue, and steatosis and diabetes and insulin resistance, and nothing gets in the way of the DAA SVR. But as Marcelo said, it's important to see the patient as a whole, not only the liver and not only hepatitis. It's a human being, and we have to see the whole picture and try to address all these his problems. So I'm especially concerned that after SVR, some patients are sent their way and people say you are cured. But I think you have to pay attention to these little details. The devil is on the detail, right? The Americans say the devil is on the detail. So if the ALT doesn't come back to healthy values, let's say 15, 17, not just below normal, but healthy, 15, 17, then you might have a patient that you cure hepatitis C, but underneath hepatitis C, he had probably some steatosis or NAFLD or MAFLD. The names keep changing, but the disease is the same. It's fat in the liver, and that today is in the high. We shouldn't miss this patient, right? So okay. Another thing you use for rescue therapy in this patient, you use GP plus sofosbuvir, because that's our Brazilian. That's the way you can rescue. We don't have Sofvelvox, right? But some people say you could rescue with only GP for 16 weeks because the patient probably, well, he was not exposed to a protease inhibitor. So he probably had a NS5A RAS. So if you only have one RAS, be NS5A or NS3, then it's okay to use GP alone without sofosbuvir. But if you have both RAS, then you should go with soft plus GP. But we don't have RAS testing. The patient was not exposed to, but he could have a native RAS. So I think it's a wise choice to go with sofosbuvir plus GP, right? So I just want to ask Marcelo one question, or Suzanne, if you think the forgiveness, because forgiveness is the ability of a drug to forgive you if you miss some doses. So if the forgiveness of 8 weeks is the same as 12 weeks. So if the patient misses 2 or 3 doses, but he's taking only for 8 weeks, or if he's taking for 12 weeks, you think it's different? The forgiveness of the therapy.
Hugo, I'm going to be guessing with the answer. If if the length of the forgiveness is similar, for example, 4 doses or 5 doses, no? If you are in a treatment schedule of only 8 weeks, probably that's going to be more important than if the treatment is 12 weeks. And that's just speculation, because, you know, we haven't checked that. But again, when I show you the Simplified study, in the Simplified study with soft bell, they used to 35% of the patient, they did have 7 pills that were missed, no, and they did have the similar response rate. But if you are going to have a schedule that is much shorter, probably you're going to be in a higher risk. But we have not done such a study.
One last issue. In Brazil, we don't have pangenotypic for. We still have to genotype because of a cost issue. So you think for elimination, pangenotypic is necessary, or can we do like Brazil and keep non-pangenotypic?
Well, it's going to be much easier if you go with a pangenotypic, because the gap that you're going to have is that you're going to need to train which is going to be the ideal treatment to a primary care physician. And if you have 3 or 4 different treatments, the primary care physician probably is going to be exposed to do a mistake or to miss the boat a little bit. Therefore, if you want to have an impact and truly enhance the number of primary care physicians treating, as simpler the treatment, much stronger the engagement of the primary care physicians.
Just a comment on forgiveness. I was just speculation. I was thinking there's a proportion 8 weeks and 12 weeks, and also when it is the patient forgets the treatment. If it's the beginning of the treatment, when the level of virus is high, perhaps it's much worse than if the patient forgets in the end of the treatment, when maybe the patient is already with undetectable levels. No? I think this is something to think. And to think on this, I was also thinking during the presentation, because of COVID, many point of care exams was developed for COVID. Maybe the technology can revert to other diseases like hepatitis virus, and maybe we can have a rapid test to check the patient if it's negative or not in the beginning of the treatment. Then maybe we can shorten the treatment of hepatitis C in the future. No? And just an idea.
Susan, that's right. I mean, there are several companies that had been working on developing an assay able to check for SARS-CoV-19 and Hep C at the same time at the point of care. But that I know they are far away from the commercial use. And we need to open our minds and start thinking on improving our care of these patients based not only in the diagnostic but also in the treatment new technologies. For example, are we going to be able to have a hepatitis C vaccine with the new platforms? No, because we did have some restrictions with the old platforms, but they have been able to develop such a good vaccine with these technologies. Could they probably develop vaccine for HCV that is also an HCV RNA? No. So there are a lot of things that if we think positive, we can probably, from the hepatology group, we can push the companies to move forward on that direction.
Yes. Also,
okay.
I would like us to...
Okay,
carry on, Susanna. Carry on.
Just to share our experience, we work in a tertiary hospital, and we need space to see patients in the transplantation list. So with the treatment of hepatitis C virus, we had 2 periods to see patients. And with the treatment, the patients decreased the number. So we closed 1 unit of hepatitis C patients treatment. And we are receiving only patients that needs liver transplantation. But to keep in treating patients, we opened a secondary level at a space outside Hospital das Clínicas. It's an outpatient clinic called Várzea do Carmo. And there we have hepatologists and gastroenterologists treating hepatitis C patients that do not need to come to a tertiary level. So maybe this can be a solution to treat more hepatitis C patients.
Okay, Professor Heiner.
And also just one last thing, micro, because what Suzanne said made me think about all the things we are doing about micro elimination. So we go into dialysis units and try to find the patients, and HIV patients. We try to see who is positive for. So a lot of people in prisons, a lot of people are doing micro elimination. And that's, I think that also is we cannot just be sitting in our offices and waiting for the patients. Now we have to look the patients where they are.
I agree. That's why I mentioned the word outreach. You know, outreach in some way for diagnosis, for care, for treatment, for cure, for follow-up. We need to get out of our offices. There's no question. But if you divide the universe of patients in the simplified and non-simplified, with the simplified, you can go straight forward, and the complicated cases, I mean, we, the hepatologists, can probably need to improve the outreach and move where the patients are. And I agree 100% with what Suzanne mentioned, and you in Brazil and we in Argentina have experience with the ECHO project, you know? And with the ECHO project, we did that in a prison, and we treated all the HCV positive patients in the prisons. Initially, we went there physically to test them, but for the treatment, we coached them through the system, through ECHO. So there are a lot of combinations that can be done if we have a very clear objective and we discuss what are the materials and methods, like in an abstract, you know, Hugo? Exactly the same.
Before I move on to Professor Wedemeyer conference, I'd like to listen here. How can you thinking and how can you manage your hepatitis C patients in Germany about the microelimination for these patients?
Yeah, so I think we have the same discussions around the world, but we have slightly different, let's say, issues and hurdles. I gave last Thursday a presentation where we also talked about microelimination in distinct German settings, what are the problems. And I started off with the New England Journal paper showing the example in Egypt. The New England Journal paper describing this, to me, most impressive screening approach in medicine ever. It's really amazing where they screen top down. They targeted to screen 60 million adults. They screened 50 million adults for hepatitis C. They identified 2.5 million HCV individuals and treated 1.5 million. I think it's, and what this shows to me, we can talk a lot about advertising and we can talk about point of care tests and small things. In the end, if we really want to be successful, it must be a top-down approach. And then it will work. We need political will and we need to fight for and in Germany, it's awful, I can tell you. And you know, I've been quite sometimes in Brazil and in South America and years ago, and I still cannot, I don't have the numbers how many patients are infected with hepatitis C. I don't in Germany. I don't have the numbers of HCV even in prisons. We've been talking about this for 10 years that prisons are the, it's awful. And we, the only thing is we have to keep going. We have to keep fighting. We have to advertising. We will have a new policy summit. and we have the same issues. What is helping is really easy treatments. It's not so much for us in Germany, the problem is who's actually treating and keeping them on treatment. The key point is really bringing them into the cascade of care. That's a key point. And we have the same hurdles like everybody else in the world. So that's why I can say a little frustrating, I have to say.
Didier, would you like to comment in a few minutes, because I need to move on to Professor Wedemeyer conference in France? How can you manage your patient to eliminate hepatitis C so far?
Hepatitis C is declining clearly in France. So we try to reconnect patient and to try to find patients who are still at risk or not, who have been seen in the past 20 years, who are not coming anyway. So we have tried to develop some policy to try to treat the maximum of our patients, and we still have some few patients who are not being treated, but I think it's now a very small group.
Okay, Anna, I think I have to introduce Professor Heiner Wedemeyer to present. Professor Wedemeyer, he is a professor and chairman, Department of Gastroenterology, Hepatology, and Endocrinology, Hanover Medical School. Thank you very much, Heiner, to join us in this meeting. You're going to present the mini conference in 15 minutes, what the future holds in hepatitis Delta. Thank you very much for your participation in our meeting.
Okay, so thank you, Laila, and thank you everybody for involving me. It's great seeing you all, even though only virtually. Marcelo, Hugo, Didier, Monica, it's great seeing you all. And my task is indeed to discuss with you the Delta issue, which is a very interesting and dynamic story. So let me just tell you briefly what we are doing right now and what the future holds, and the future started at least in some European countries already. These are my potential conflicts of interest, and I have to highlight that this includes companies currently developing drugs against both HBV as well as HDV. So short introductions. The number of Delta patients worldwide, it's still we had several meta-analyses in recent years. I will touch on in a minute. I wrote here 10 to 25 million. I wrote it that often that I believe it could be true, but let's say all the data that we have been seeing and discussing is really heavily biased, and the problem we simply have not a good answer. And I have to highlight that Delta may not be transmitted by HBV envelopes, as we have learned, at least in vitro, and also in small animal models. Other envelopes like HCV or VSV may be able to transmit Delta, and you may find Delta like viruses even in bats or in snails. Really strange data in recent years. So far, so good. I was keeping telling it doesn't matter until February this year, when this paper was published in Hepatology, where they screened in Venezuela 160 HCV RNA positive patients who were negative for HBV markers. And then indeed, they found two patients, S antigen negative, anti-HBC negative, but Delta positive. And one of them carried also Delta RNA. They could sequence this and found it to be HDV genotype 1 in the absence of S antigen, which is really weird, I have to say. The big question is really, is this really something which is clinically relevant in the long term? My first question was this Delta transmitted really by HCV or by a completely different bug? We don't know. Or did these assays fail for some reason for the B markers? But I have not an answer, but it may be that the Delta will give us more surprises in the next years again. So you're all aware of the different HDV genotypes worldwide. We have genotype 8 here. it's really diverse disease, but it's also important that we have a lot of environmental factors in Africa, in Asia, in Mongolia that may contribute to the heterogeneity in the outcome. I mentioned the issues about the global prevalence. I think the best meta-analysis is this one from Alex Stockdale and Anna Maria Giretti, and they really distinguish two different settings, which I think is important. The general population and then hepatology clinic populations, because most studies are heavily biased by referral. And you can see here that in general populations, everything is green or no data. So we really have very, very low delta prevalence among S populations, while in patients with liver cirrhosis, you may have rather high prevalences. And this is the big question: should we really screen every S antigen positive patient or only patients with advanced liver disease? This is something to be debated. My message for Germany, at least, is that we should screen every S antigen patient at least once for anti-HDV, because every patient we miss a big chance to treat him. And as the costs for Delta antibodies is not a major issue here, so this is my recommendation, not to miss somebody. If you then find the antibody, we should go for Delta. And here the key point is the assay matters. In-house assay may miss HDV RNA, and also the RNA extraction method even matters. We shouldn't forget HB virology. Staging of liver disease is, to me, important. And I biopsy most of my Delta patients to really check whether there's HDV-induced autoimmunity, which is not infrequent. And I think this has clinical consequences, as I would not use interferon in these kinds of patients. And this is what we are doing still right now. And then the question is why to treat, because Delta is causing severe disease. This is data from Sweden, where you can see if a patient is starting off with cirrhosis, it's really a malignant disease. You're losing half of your patients after 5 years. And you have to go for RNA, because those RNA positivity, which is not trivial, really has been associated with a more severe outcome. So we have been using interferon for quite some time. Overall, roughly 1/4 to 1/3 of patients may become undetectable, but late relapses occur. Still, even the relative HDV RNA reduction without complete elimination of RNA has been associated with an improved clinical outcome, and this is data from a variety of countries, including France, England, Germany, Turkey, Italy, etc. This is the old HIT-1 trial, which I also presented quite some times in Brazil. Why I'm showing you this old data exploring 48 weeks of interferon, it's because we just published the 10-year follow-up data. And this, I think, is very important, because there are some patients who presented with very late relapses. So there is no SVR in Delta as compared to HCV. Look at patient 207. This patient had been HDV RNA negative at the end of interferon-based treatment, negative, and he became positive 7 years after initial response. And it was the same virus, at least by sequence, which I think is remarkable. And this shows you that if you have a Delta patient, that you really have to follow your patient, in my view, maybe even lifelong, to exclude very late reactivations. And as the initial trial explored 48 weeks of treatment, the question was, what if you treat longer? And here the short message is, torturing your patient for 96 weeks with interferon does not help, because still these patients, even after 96 weeks of interferon-based treatment, may experience relapse. And numerically, there was no difference with 48 weeks versus 96 weeks of interferon-based treatment. When you measure viral load on treatment, it's important to have a sensitive assay, because if you detect low levels of viremia during treatment, and these are the red bars, so they are negative with a less sensitive assay, but positive with a more sensitive assay, that these patients have a high risk of relapse post-treatment, and only those patients who are really negative by even the sensitive assays, they have a very low risk of post-treatment relapse. So the assay matters, and that's something which is really important. I mentioned that if you respond to interferon, it's a good thing. and then you improve your clinical outcome. These are just one examples. I don't want to go too much into detail here. So it's worthwhile of trying interferon. The one question that I'm frequently asked, should all Delta patients receive NUCs against hepatitis B? And there have been some studies suggesting that long-term tenofovir treatment may be associated in some patients with an HDV RNA decline. This is data from triple-infected patients, HIV, HBV, HDV, and they received tenofovir to treat HIV. And some patients had no effect, others had this decline, but importantly, all patients remained S antigen positive. And let's say the cause for this HDV RNA decline may be different from each individual. I am not treating all my patients with Delta with tenofovir as a backbone. I only do this if this patient has advanced fibrosis or cirrhosis. So let's say that's the current status. What's about new drugs? And there's a lot of things are ongoing. Let's first start with interferon lambda, so that you know that 10 years ago there have been programs at that time by BMS for B and C to treat lambda, and lambda works in mouse models, as has been shown 4 years ago. And this was a trial that was performed in New Zealand, in Israel, and in Pakistan. And you can see here a dose-dependent decline of Delta RNA when being treated with lambda. And the company Eiger took this program over, and they are now initiating also a phase 3 trial to explore the effects of lambda. Then we have nucleic acid polymers, which have been, let's say, presented for quite some years. This is the REP 3129, and this is something you see here, remarkable S antigen declines and also HDV RNA declines. The drug has been first used as a monotherapy, then interferon was added for some time, and then a complete 48 weeks of course of interferon was completed. This is the first trial. These were 12 patients treated in Moldavia. That's all. We don't have more data, even though this data looks spectacular, but these HDV RNA declines have also been associated with significant ALT flares, and this is really an issue which we should not forget. Then there has been prenylation inhibitors have been explored, which is currently lonafenib. So prenylation is somehow interferon with virion assembly and packaging of viral particles, and this is the drug has some low GI side effects. Gianodidin published a dose-finding case series in Hepatology 3 years ago. Here the phase 3 trial is ongoing. And then finally we have entry inhibition. This is bulevirtide, formerly called Mercledex B, which is a peptide derived from the large HBs antigen. And this is in the end competing with normal S antigens for entry into the cell. So it binds NTCP, the bile acid transporter NTCP, and it shows a really strong inhibitory potential. And as NTCP is only expressed on hepatocytes, it exclusively targets liver cells, which I think is very important. By the mode of action, it was to be expected if NTCP is a bile acid transporter, that bile acid should increase during treatment, and this is indeed the case. So bile acids increase, and if you stop Mercledex, it immediately drops back to normal. And this is important, that as none of these patients really showed itching in the trials. So bile acids per se do not cause itching, which I think is proven by this trial here. And it's also a dose-dependent effect. The more Mercledex B was given, the higher the increase of bile acids in the blood. During treatment, there's an HDV RNA decline, which is linear. You can see here after 24 weeks of treatment, most patients relapse, even though some patients maintain a virological response, few, but some do. And that will be interesting to see whether longer treatment is associated with a better response here. But, and this is strange, so this was HDV RNA, but if you look then at HBs antigen, nothing is happening. So this is the difference. So HDV RNA is declining, probably reflecting loss of infected cells, but S antigen remains stable. And this means that this S antigen is very likely derived from integrations to the human genome, and that the space with loss of HDV infected cells is filled up with non-infected cells carrying in the human genome HBV DNA. And that's something that we should keep in mind here. So the drug has also been used in let's say clinical case studies, and this is a 2-year data, and they have been using this also for 3 years now, which were presented at EASL, that there was long-term efficacy, and that's all I can show here. The drug has also been used in combination with interferon with some strange results, because on treatment there was a synergistic effect of HDV RNA suppression in terms of more doses, that more HDV RNA suppression. But in terms of S antigen, there was an inverse dose effect, as you can see here. And we believe that the higher increases in bile acids may have counteracted interferon responses. So this is something we keep in mind. In Germany, we have the drug now available. I can prescribe it. The bulevirtide has received conditional approval by the European Medical Agency, and I can use it in patients with chronic HDV infection with compensated liver disease, I think, which is very important. And as usual, you know, I'm always showing this slide that also Delta patients should drink enough coffee. It's good for the liver, and it's a dose-dependent effect. Thank you very much.
I think the debaters could be mention some words about the new drugs and some things beyond. Come up to Hepatitis Delta.
Okay, Heiner?
Didier, please.
Yes, I have only the experience of bulevirtide, but my feeling is that in patients who are non-cirrhotic, it is better to combine interferon, PEG interferon plus bulevirtide. So what is your advice on this?
So I can tell you that I do not use bulevirtide yet in combination with interferon outside of clinical trials. The evidence that we have is only based on 7 out of 15 patients, which showed an off-treatment response and S antigen decline. I think we need, and Tariq Asselah presented the data of a new trial at EASL showing, let's say, no big surprises, some more patients in that trial. At this, it really depends what you want to achieve. If you have a patient where you want to go for S loss as a cure of both diseases, yes, then you may combine it with interferon. But again, very small numbers, and then you want to go for finer treatment. If you have a patient with little advanced fibrosis, I do not go for interferon. Because there the goal may be either for maintenance treatment with bulevirtide, which I think is a good idea, and whether we can stop after 2 or 3 years, this is something the trial will tell us in 2 or 3 years. We don't know yet. But at this stage, I don't take the risk of flares. I have seen also in the trials reactivation of autoimmune features or phenomena, and therefore I'm, let's say, rather careful in broadly recommending this, unless the patient has really low S antigen, and if you really want to go for finer treatment. But I know that in France it's quite popular, that in the program there many patients have used it with interferon, but I can tell you outside of these clinical trials, we did not use it to a large extent, and in Germany definitely not.
Heiner, you know, I live in the south of Brazil. We don't have much Delta here, but the few experiences I had, including the US, in Miami, where I trained with there were some Delta in the immigrant population. Sometimes we use long-term interferon, which is about 5 years, 7 years. I saw a case in NIH, 12 years interferon nonstop. Well, they tried to stop, but Delta kept coming back, and so they kept interferon monotherapy. And people tolerate interferon monotherapy in hepatitis B much more than hepatitis C. I think because we don't use it for ribavirin or something. So what's your experience on keeping a patient long-term on interferon?
So two answers. First of all, the better tolerability of interferon in B mono, I cannot subscribe for delta. So this is my experience. They still have problems to tolerate that one. Yes, there are some patients who tolerate long-term treatment. And the NIH group, they just published their long-term follow-up in APNT of a trial where they explored up to 5 years and single patients even then extended. Yes, it's possible in single patients. And then you may play with the dose. You may go down from 180 to 90, which is also reasonable. Again, this is now really personalized infectious medicine. So this is, I don't argue that that is not possible in single patients, but we're really talking about single patients. And I think I strongly advise against general long-term use of interferon. My term is, when do I extend treatment beyond 1 year? And then only if I really see a decline in S antigen. That must be the goal. If I have the chance to use S antigen, then I extend based on a single patient my interferon dose. If I have a flat S antigen, I stop after 48 weeks and I don't go for longer treatment.
Heiner, may I?
Sure.
I'd like to change a little bit the topic towards what you presented, those D patients with B negative and C positive. No? That's kind of impressive. And, as a hepatologist, start thinking on where else should we searching for delta in other patients, like a long time ago we did with hepatitis G, and it was a fake one, no?
Yeah.
So what is your advice with this?
So I don't have a good answer on that one. I think it's scientifically extremely interesting. And I'm afraid that we may overlook a biological phenomenon which may be much more frequent, not only for Delta, but also for other bugs, which is extremely interesting. Even having seen this data from Venezuela, so the first measure is I do not screen all my HCV patients now for Delta. That's the first point. The second point is, even though I would treat my HCV patients and take away the envelope, so I should treat my Delta with this one anyway. So this doesn't make sense, but you're absolutely right. What's about this unexplained hepatitis causes? So is it drug induced? Is it autoimmune? Is it a little NASH? Right? So we all know these patients, and then in the end we come up, it's a little drug induced or it's NASH, and then we are happy, and then we're doing our fibrosing when we hope that nothing is happening. So that's the point. We may need to go back and to screen for these kinds of bugs and do maybe with the new techniques when we do microbiome screening, we may need to go in these patients to a virome screening to really look for new friends which we haven't realized yet. So I think it's very, very important. And then therefore it's for us important. We really have to identify these patients. We have to characterize them very well, and maybe different in Argentina than in the Venezuelan area, than in Germany or in France. So I think that's no clear answer, but I don't know really what to make out of this data at this stage. It confuses me. And as I mentioned before, in Venezuela, we may not even know whether HCV was the transmitter. Maybe they had dengue. And dengue was transmitting in an HCV patient the Delta. I don't know.
CMB, EBV.
Heiner, what about the benign Delta? A Delta that's just benign and is not doing anything with the fibrosis, and the patient is an inactive carrier with Delta.
There are these patients, you're right. So not heavy, and I showed you the Swedish data. If cirrhosis is present, it's really malignant. But the other group of patients, we were remic and did not have cirrhosis. It was not as bad as we are always showing. So there are patients. Therefore, we may not, also coming back to your interferon, and I have young patients here, I keep telling them, just wait. And there will be drug developments, and there is, if you go to clinical trials, we may have completely different ideas. So the siRNAs against hepatitis B, which make a decline in S antigen, and in clinicaltrials.gov, you can see that Janssen, for example, is performing a trial in Delta patients. So it could be very well that every 4 weeks, an injection of an siRNA to reduce S antigen may be a very nice option for Delta patients. So completely different ideas in the long term, and you may not need to torture all patients with interferon or lonafenib or other strange drugs.
Did you see a connection with this benign Delta with Delta genotype?
I cannot tell because in Germany, 95% of our genotypes are genotype 1. Maybe, I don't know, and there's data from King's that genotype 5 may have a better course. Didier may see in Paris some African cases which we don't see here. There has been reports 15 years ago from Asia that genotype 2 takes a better course than genotype 1. And again, we have only data for genotype 5 from King's, that this may also not be as bad as genotype 1. But for us, it doesn't matter because I have only genotype 1s here. And you in southern Brazil also genotype 1 only.
Okay, can I talk something?
Ana, Ruth from Amazonia, and Suzanne as well. Would you like some comments of the...
Yes. Hugo is from South EU. I am of Amazon. Then here we do interferon in the first year, PEG interferon, plus tenofovir plus entecavir. Then we do the first year or the second year the interferon. If we can, we do also a long-term interferon, but it's very difficult at the intern of Amazon. That's where we have the most of the case of hepatitis delta. Then we have many young cirrhotic patients that we have good answer with this treatment, interferon plus entecavir, the first and second years. If you can, we do also long-term interferon. That's our experience. And the genotype here is genotype 3. It's very more aggressive genotypes than all of them, I think so. Thank you.
And in terms of hepatitis B, it's mainly genotype F or A. What is your frequent one? The hepatitis
F.
B.
F.
Yes.
Hepatitis B, F. Yeah.
Suzanne?
As Hugo Schenken mentioned, here in São Paulo, we do not have hepatitis delta. The only patient we had came from Amazons to treat us, and he came already with the diagnosis of delta. So we do not screen for delta here. But after you mentioned, it would be wise to check for delta, but we don't have the resources. So if you could give us a hint, which patient should be screened for delta, like cirrhotic patients that are not going well with, is there any group of risk for delta, except of origin, Amazon
So
origin?
I think the cirrhotic patients is a must. I think it's you need to screen all your cirrhotic Bs for delta antibodies. I think this is a must to do. And then it's a matter of resources. So if you treat your patients with entecavir, tenofovir, and if these patients do not normalize ALT, then I would also go for anti-HDV testing. So these are the two groups of patients where I think there's no doubt that you have to go for this. I agree that if resources are a problem, if the low viremic carriers, that it may not be immediately necessary to screen them for anti-HDV, as anyway there's no practical consequence out of this one. but still you may have fluctuating courses. So it's a matter of resources. For us in Germany, we recommend to screen everybody, not to lose someone, because if you the GPs and everybody, they need to follow so many guidelines. They need to follow this guideline, that guideline, that guideline. And therefore, for us, it's more important to make it as easy as possible. And the easy recommendation is S antigen positivity automatically should mean anti-HDV testing. If this is not affordable, all cirrhotic patients and all patients with elevated liver enzymes, despite sufficient antiviral treatment with tenofovir or entecavir.
Heiner, do you agree that anti-delta IgM is similar, or you can use as a surrogate for RNA? If you don't have the RNA, could you use the IgM, anti-delta IgM, as a sign of active disease? Active replication.
There's not so much data and not so, let's say, the assays around maybe not as good. So we published 7 years ago a paper where we indeed tested for anti-HDV IgM, and this correlated with disease activity and also to some extent with RNA. But in the end, it does not really, let's say, if you really base a treatment decision on this. So for example, if you want to start interferon, yes or no, I would rather prefer to have an HDV RNA and to have an S antigen. If this is for whatever reasons not available, then yes, IgM may be something that may be useful, but a lot of maybes. So because we have, fortunately, here RNA available, I haven't used IgM testing outside of research projects during the last, I don't know, 8 years or so. I simply did not do this. And the data is not very good.
I have a lot of curiosity about Delta because I don't see it every day. But I understand that usually the Deltas I have seen, the E antigen was negative. But there are some people that they have Delta with E antigen positive. It's difficult to imagine because Delta inhibits replication of B. So do you see usually E antigen positive with Delta in your case?
Well, our friends from the Amazonian area may comment because they should see this. And we published 10 years ago in Liver International a paper on E antigen positive Delta. So in the early phases of HBV infection, you have also Delta, and the young patients, in our experience, is 15% of the Delta patients who are E antigen positive. Anna, do you want to comment? Are your patients in the Amazonian E antigen negative or positive? The Delta. Anna Ruth.
Anna, your microphone is on.
They are positive, the major part. I think so, yes.
So the younger one, but what is still interesting so Hugo, in what is quite strange, in Delta, you can find E antigen positive hepatitis B with a DNA of 500 or 1,000. So very low HBV DNA, even though they are E antigen positive. And this really shows you that Delta is suppressing HBV replication in all phases of the infection, which I think is pretty cool. This has been under-recognized. So low DNA, because in the mono-infected patients, the seroconversion occurs between 100,000 to 10,000. And I have seen in mono-infection, let's say E antigen positives, they all have above 10,000 HBV DNA. And I only saw in Delta E antigen positivity with very low HBV DNA.
So Heiner, if Delta is already inhibiting B, why do you need entecavir or tenofovir, right? Tenofovir or entecavir shouldn't do anything for Delta.
Yeah, it's a good point. It should not do something for HDV RNA. The only question is whether reducing B from, let's say, 500 to 0, whether this is doing something good. And you're absolutely right. You're absolutely right. There is no evidence that using a NUC in Delta patient is improving the outcome. There's only evidence in the opposite way. So when you look at our hepatology paper 2017, I only showed you here interferon yes or no. But if the interferon no population, you would split up to those who received NUCs and who received nothing. The nothing patients went better than the NUC patient. However, this was obviously biased because the NUC patients were more advanced because you have nothing in your hands and then you get the NUCs because you want to do something. But I agree, there is, in the end, there is no evidence at this stage that Delta patients benefit from NUCs.
But you think also to prevent reactivation of the B that is low viral load, yeah.
Yeah, I think that's a good point. And also when you reduce by interferon, for example, Delta, that then B may come up. This is always the risk that we may see, but this risk is not very high, I have to say. It's not. We have, for example, with bulevirtide, with Notrudex, when we use reduced HDV, there was one study where no tenofovir was given, and there was no B coming up really, which was to me surprise. But it's again with an NG inhibitor, so I think many issues that we have not understood yet completely. But I agree. On the other hand, I don't think it's a big mistake in using NUCs, but to answer Hugo's question, on the other hand, there's also not much data really supporting that we're improving the clinical outcome, quite frankly. That's a good point, Hugo.
Maybe in the Amazon.
I think many times, but I needed to finish, unfortunately. I thank you very much indeed for everyone. You have 1,305 participants in this meeting. And before I close this section, I have to say that my Luciano moving on to London on Tuesday, and I'd like to say his farewell from the meeting today to speak in German. We see you, Heiner.
Dankeschön, Professor Heiner, für alles. Ein großer Freund hier von Brasilien. War ein exzellentes Sprecher. Und nächstes Mal wieder sehen hier in Brasilien oder in London. Dankeschön. Muchas gracias, profesor Marcelo Silva, por la amistad a los brasileños que han estado otra vez aquí con nosotros en Fernando de Noronha. Nos vemos ahí otras veces. Un abrazo a los hermanos argentinos. Y al profesor Didier, merci beaucoup. Au revoir.
Bitte. Ciao.